Welcome to Engaging with Psychoanalysis. I'm Tom Schumann. I'm a mental health counselor interested in better understanding the theory, history, and practice of psychoanalysis. I aim to do so through discussions with practitioners, thinkers, educators, and others involved in the psychoanalytic tradition. If you're interested in being a guest on Engaging with Psychoanalysis, please email me at engagingwithpsychoanalysis@gmail.com. Thanks, and enjoy the show. In this episode, I speak with Bobby Bowie about integrating psychodynamic therapy with other psychotherapeutic modalities and psychological points of view. Dr. Bowie is a licensed psychologist. In addition to teaching clinically focused courses at SUNY New Paltz, he provides psychotherapy to patients and conducts psychological testing. Enjoy the interview. That's looked a little different over the years. So I wonder, though, right now in your practice of psychotherapy, what that tends to look like, with the understanding that it probably looks pretty different from client to client.
I think because I think the client, I mean, I see children to adolescents to adults. And then when I work with children and adolescents, I actually work with their parents as well. So obviously it's just not the same structure as what you think is a lot of people think is, working psychodynamically. But all that informs, I mean, psychodynamic theory is probably the most comprehensive in looking at developmental issues, right? And putting emphasis into that. So when you're working with young people, you're kind of you obviously you look at their early development, but you're actually a huge part of that process, right? And you can actually, I would say, if we want to talk about how they're still developing their identity and understanding who they are in the world, I mean, you're kind of a lot of it is you're a part of that, and I think uh, in that sense, it's useful to have that theory, even though they're obviously they're not adults, and we're not always looking at conflict,
Hmm.
intersected conflict. Yeah, so that way. So
It sounds like it's a grounding from which you can hold it somewhat lightly, but you can also use it to frame these patterns of development that you come into contact with when working with children.
yes, yeah, because even with young kids, even their identities are still forming, and there are huge variations in how they present themselves, and obviously there are things that are more innate. So children are born with different temperaments. There's conditions like uh, autism spectrum, where they are in the spectrum. So in those cases, you're working with them, but yeah, they're coming with different strengths and challenges. And so, but the development you're obviously looking. I'm always looking at through a developmental lens, right?
Mm.
To see how these things might have impacted them, from birth on, to when I see them. So
So, taking a psychodynamic view of development, how much does that stick to kind of the classic Freudian stages of psychosexual development, or how much is it based on later contributions?
I would say much more later contributions. I mean, it's not that I don't believe in like what Freud was talking about, because if you look at Freud's psychosexual stages, I mean, I don't think everyone buys into that anymore. I think most psychoanalysts don't, but there are aspects of it that people have extrapolated. I think whether you're talking about Erickson's theory of psychosocial, which incorporates more about the child's early environment with its caregivers, object relations theory, obviously, and then also attachment theory.
Hmm.
So even though no one really says, this person has oral issues or anal issues, we know that early development matters. And we have other theories now that kind of grew out of what Freud was writing about, like attachment and object relations, that really inform us about like how early patterns in relating influence relationships later on in life, right?
Hmm.
Influences a sense of self, influences self-esteem, ability to initiate rather than doubt, etc. So all that I think, is there. um, but not in the way that Freud used that language. I don't think anyone really thinks that way. You can sometimes when I'm teaching, I try to say, this is what Freud probably meant when he was talking about dependency in the oral stage.
Mm.
But I don't think when I'm sitting with patients, I don't like thinking like they have oral issues or anything. I don't, yeah, and I would never use that language with a patient or when I'm writing something. So,
One time, this kind of brings to mind. I was talking to a therapist who was very much cognitive behaviorally oriented, and Freud came up, and the stage of psychosexual development came up, and the way he saw it and the way he phrased it is, he said it's very good and somewhat accurate poetry about development. And I'm not sure if I'm of that mind,
mhm.
but I think it's a very interesting thing to say.
But I think it's more than poetry, or and Freud was definitely not just prolific in his writing, but really, I mean, he was just a strong writer in the sense of being able to explain what hadn't been explained previously in the field. And so I don't think it's just poetry. I mean, Freud didn't work with children, but he listened to people enough to recognize patterns that probably had to come from somewhere. They patterns in relationships or patterns of responding to the world or ways we think about ourselves don't just develop spontaneously. And he wanting to kind of work, and no one kind of works that way. We kind of work forward now, right? We get, with the work of Anna Freud and Melanie Klein, we work with children and we see how they develop, and we can develop the theories as we're following them. And that's how, like, I think modern developmental psychologists look at it, right? Because they do longitudinal studies, but Freud didn't work that way, and that's the criticism for that he worked backwards. He was extrapolating from, what potentially could have happened in early life to lead to these symptoms, right? What early trauma or what deficits would lead to this. So, uh, it wasn't the best method, but it's definitely more than just like good storytelling or
Mm.
poetry. It's more than that. So I could see one wanting to criticize Freud in that way, but I also don't think it goes that far to just being something we read and it sounds beautiful about development. If that were the case, then attachment theory, well, we originally started and was influenced by psychoanalysis. Um, Obviously, Eric Erikson, their theories would not have informed modern day developmental theory
Hmm.
if it was just, um, kind of like a fictional narrative.
Yeah, yeah, and I'm not sure that the intent there was necessarily to imply that it was fictional as much as,
Hmm.
well, we don't have to get wrapped up on this anecdote, but the way that you're kind of framing the foundations of psychoanalysis of Freud, it's kind of like, no, it was incredibly significant, but ultimately, and why wouldn't it be? It was insufficient because it was the
Hmm.
beginning of something that had to
Right.
grow and grapple with the different um, theorists
Yep.
who emerged and who,
And
yeah,
tested in the field, right,
yeah.
by other people who are practicing, who are saying this piece, this element works, this is there, this is not. Let's revise this, like any science would, right,
Mm.
or any practice. So yeah, I like how you described it. That yeah, it was a foundation to build upon that. Yeah, is insufficient, and it as it should be. It's this is he started it, but he has. I always say when I teach, like Freud has, we have to teach Freud because he basically has the first word, but he doesn't have the last. And then as we go through and learn the other theories, you're going to see how talk therapy has developed since Freud's, works, his writing.
I hope we're not getting too tangential, but do you feel that in developing past Freud, anything's been lost, anything that was really valuable in Freudian thought, that has maybe fallen to the wayside, unfortunately, rather than as a part of evolution of psychoanalysis and psychodynamic therapy.
I think very little has been lost just because so much has been um, redefined
Mm-hmm.
in other orientations that were achieving the same aims or basically doing the same thing as what Freud was doing. So if like you were bringing up like people who like cognitive people. Well, they talk about schemas and cognitive schemas for relationships as if, we can recognize this with somebody in a session. And I'm just saying, yes, you can recognize that. And Freud was picking out relational patterns, and so were the object relationists and the interpersonal analysts. But what the cognitive behaviorists aren't really caring so much about is how these cognitive schemas are formed. And I
Mm.
think it's because when you're teaching cognitive behavioral therapy, you're not looking so much, the emphasis is not on history. They don't have a developmental platform. I mean, you go into any cognitive behavioral, uh, even the best, Beck to his daughter Judith. I mean, you don't see a developmental model. Or if you do, it's a very it's brief, it's limited.
Mm-hmm.
So they're not looking at that. They're looking at this as cognitive pattern of entering relationships that the person repeats that is harmful, that's distorted, but not looking at the way a psychodynamic therapist would because they're not looking at development. And so, in that sense, these certain things haven't been lost, right? Um, and we can. I'm not saying that the cognitive behaviorists need to have a developmental theory because I think if you are doing the work intuitively as a therapist, you're kind of looking at that already.
Mm-hmm.
Like they may not know uh, attachment theory as well, but they could probably, most therapists working in a cognitive behavioral frame could be like, this person has been relating to people like this probably much of their lives,
Mm-hmm.
or or since the time where the symptoms have developed, right? That they were unhappy or the relationships they can't sustain, and those things can go back to childhood and they'll look at things like I see a lot of cognitive behaviorists talk about like this child was bullied, right? And so they have this idea of what relationships are now,
Mm-hmm.
right? Like they're afraid to approach people, they're anxious. So so I mean, they don't really emphasize it, but I do think they think that way. I would imagine it would be um, very incomplete in looking at somebody if you didn't consider their history.
Yeah. And,
Yeah.
and I mean, and even the idea of the schema, it's not it's not conscious, like in my
Right,
understanding of it, but it's implicit. It's an implicit way
right.
of organizing thought,
Of
um,
course. Yep,
which is in the most technical sense, it's psychodynamic.
definitely. So they call it, so they have other words. So they don't use the word unconscious.
Hmm.
They'll say these are, like you said, implicit.
Yeah.
So that's really thrown into their literature. And so in that sense, I don't like you don't have to go to war with people with different theater orientations. If you have this integrative approach and you're studying the material, you're gonna, like I said in the beginning, you see how the way we're practicing, even though we may use different language, comes out to be almost the same when we're in the session. I wouldn't say exactly, because obviously psychoanalysis has and psychodynamic therapy has things that are unique to itself. But yeah, I think that in that sense, that's where I think I don't have to go to battle, and I think that's where we have problems a lot with different people from different orientations thinking like we have the better
Mm.
method, and we're gonna publish more, you know,
Yeah.
empirical studies showing that we do better work. And I think that's the wrong thing to do. So if everyone would just study what everyone else was doing and see the commonalities, I think that what would help people get over that hump. Yeah.
And as I'm understanding it, you have a psychodynamic epistemology, but
Hmm.
a eclectic or integrative approach. Would that
Yeah,
be?
so even with that, yeah. So even within uh, psychoanalytic or psychodynamic theory, I pull from all of them.
Yeah.
So from ego psychology, to object relations, to classical, to interpersonal. I mean, I wouldn't say, I'm not always working from like a drive theory, but I do see patients when they come in. I definitely see certain patients with ids that are, I just feel like their entire lives, even when parents are describing their kids to me, that they work under the pleasure principle. Like they want something and they want it now. And it's really difficult to live in a world where you don't get those things. And the parents are frustrated because they don't operate that way. That my child shouldn't get everything they want when they want it. I couldn't achieve that and I don't think it's healthy. But the child comes in that way, and parents will say something, but our daughter isn't like this. Only our son is like this. Our daughter is, I can tell her to wait 10 minutes and she'll wait 10 minutes and she'll go find something else to do. He throws a tantrum. And so, and the parents are like, what are we doing wrong? And I said, like, well, let's go back developmentally. What was your son like, the first year of life before? And they'll tell you from their interactions, how the child slept, how the child, that there was this distinct behavioral differences.
Mm.
And it's not like the parents raise these children in distinctive ways. I mean, most parents only know how to parent. They're not going through these parenting classes that's just revolutionize how they parent each child to the next. Um, but the children come into the world, and in that sense, when Freud writes about drive theory and how we different in our id and egos, that is always in the back of my mind when I see people. But I don't. It's not like that drives my work. Maybe going back 30, 40 years at some of the more traditional psychoanalytic institutes in New York City and other metropolitan areas, you would probably see entire schools of analysts that worked from that perspective. That they thought object relations was just, a farce. So, but yeah, I work from a pretty integrative approach. But I do want to go back to your initial question of what we think we've lost, because there are certain things that we have lost that I think we need to bring back
Mhm.
and we need to emphasize. And one of the first thing is that Freud, in his training of psychoanalysts, believed that everyone needed to be in their own treatment.
Mhm.
And we don't have that anymore. We don't have that even at programs that where the emphasis is on development, or there's a faculty member who, like myself, is dynamically oriented. There isn't this um, belief that all mental health practitioners need to be in their own treatment,
Yeah.
and I think that is a huge loss. And I see it when I'm teaching and when I'm supervising clinicians. Um, they don't know how to figure out what is happening in the room because they've never been a patient in the room,
Mhm.
and that's really difficult to teach someone if you haven't been there. For even like I hear new clinicians say it must be very difficult to start therapy, and I said, well, how would you know?
Mhm.
From what? From what patients have told you, or was it difficult for yourself to make that call, or if you ever tried to attempt to make that call and didn't make that call? Um, is it difficult because you were afraid, like some of the patients talked about, or one goes through one therapy that initially, what if I walk into the waiting room and people see me?
Mm.
And what if someone I know is in the waiting room? And so when you go through that process, even the initial process of initiating therapy, for yourself, all that is in your head. Um, and we don't expect that of mental health practitioners. They don't go through that. Sorry about that. I
It
think
happens.
we could take a pause. I think that we're getting our propane delivered.
I'm just gonna start recording again.
Okay.
And so yeah, we were talking about how most counseling or other psychotherapeutic programs do not require clinicians or students to undergo therapy themselves.
Right. And I'm curious as what you think about that. Someone who's recently completed a program. Did you get a sense that students were pursuing it on their own, or was it something that weren't even considering?
I think a lot of people who uh, who go to school to be therapists are in therapy, just not as part of that training, but um just because there's obviously a certain faith in the process there.
Hmm.
So you'll kind of end up saying, all right, well, if people get something out of this, I'd like to get something out of it as well.
Hmm.
um I don't know how many of my classmates were actively in therapy, but I certainly got the sense that most of us had been in therapy.
Okay.
Um, I would be really surprised if anyone. I don't know. I guess it didn't come up that much, but it came up enough that it was my impression that that most people in the program had some experience as clients. Now, what is that ultimately worth? I think that depends on their experience and also, their experience as clients and also what they like to accomplish as clinicians. Because, as you said, it gives you some experience in the client role, so it gives you some insight into it. But I mean, I would think because I know that in psychoanalytic programs that grant people licenses as psychoanalysts, analysis is required,
Right.
and my understanding is that is not so much for just to get a feel for the room,
Not. Yep.
but
Yeah.
to work through certain conflicts that might come up as an analyst. Um, so obviously, for most people who are just incidentally getting therapy, that's not going to be the case.
Yes. So it's there's no like aim, right? So there's not with the psychoanalytic training, there's an aim that once you go through this process, you will work through as for yourself your own struggles, conflicts, and so they don't bias the treatment that you're going to be eventually carrying out. But also, if but also to give you the mechanisms to figure out when that's happening, right? That's not only possible but likely to happen, that there's going to be countertransference,
Hmm.
and what would you do when that comes up, and how would you know? And I think yeah, I think what you're saying, even if your peers were had at one time gone through therapy, which I think is beneficial to one's practice later on. First of all, there wasn't probably an aim to like this is why this would be helpful, and there, like you said, if you only had impressions of it, then there wasn't a discourse in the classroom or the training that allowed one to reflect on that, and to reflect on how the theories or the practice of psychotherapy applied to their own treatment, right?
Hmm.
To say like, so the things that happen when a therapist confronts the patient, that from a patient side, how difficult it is to hear that. And so when we confront patients, we do it in a very respectful and almost at times a delicate way, so that they could hear it, what needs to be heard, but not in a way that feels uh, that the patient's being attacked or criticized. And if you haven't been in your own treatment, then that's hard to gauge, because you could be like, wow, I really respect this person, and they just said something to me that was really hard to hear, and that could have been softer about it. And I think if you don't go through your own treatment, I think that falls. That's kind of like a deficit in probably in the way you practice. You take longer to learn how to do things. Um,
I think there's also something about just witnessing the therapist's role embodied by
mhm.
someone else, that is almost necessary. It brings to mind interviews I've heard with stand-up comedians,
Mhm.
and they talk about how in their first couple years they're basically just aping someone that they
Yes.
look up to,
Yep.
and eventually they kind of find their own voice. And I feel like that's probably necessary for them, and that's probably also necessary for therapists as
Right.
well.
Right. And that's everything. It's from how you set up your room, how you where you're seating, and what you bring into your treatment room, and all those things. How your own therapist set boundaries, and that you feel more confident in that, right? To cut somebody off, like our time is up, like to hear that for yourself and not feel like someone is slighting you, even though
Mm.
you were about to talk about something. So when you do that to your patient, I'm sorry, but our time is coming to an end, even though they may be talking about something that's really significant, or they're very emotional, you know that there will be time to talk about it in future sessions, and you just want to get them to a place where when they leave the consulting room that day, that they're composed. So yeah, there's so many advantages, and I think the one of the biggest advantages of being in treatment is um, like we live in a culture of managed care where we're supposed to do treatment in 12 to 16 sessions or whatever, and
Mm.
there's so many models that students learn, and they think, but if one is in one's own treatment, one knows that, in 12 sessions, what could I really accomplish? What would I reveal? Some of the Would I reveal everything about myself to someone in, my deepest thoughts and experiences, maybe experiences around shame, things would that be achievable in 12 sessions to even bring that up? And so I think it kind of lends to this idea of like, we have to be advocates for treatment, to be that people could have access to treatment for much longer than 12 or 16 sessions. And I think when you're in your own treatment, you realize how long it takes to develop a therapeutic alliance, a trust. Um, I'll say it. I'll say it to my. I think now I'm pretty good at developing rapport and an alliance, but even with that, I've seen patients for years, and things come up, 2 years into the treatment that they couldn't acknowledge early on.
Yeah.
And so I'm just thinking, how do we do this in 12 to 16 sessions? And these are, yeah. And so in that sense, I think that's what we've lost. And I don't see us getting back there anytime soon. I don't see anyone pushing for that. The most influential people in the field are not pushing for that. So,
But this is something that's kind of come up on previous episodes, and it's that yeah, I mean, as I understand it, some of it is just psychotherapy has been really reduced to a tool to get someone back to functionality.
right.
And maybe you can do that just for some amount of people in 6 to 8 weeks, but you know, processes take time, and if you're looking for some kind of fundamental change beyond that, one would expect that that would have to occur over some significant period of someone's life.
Right. And so what we're talking about is how we measure, like, functionality, right? And so empirical studies will say, 6 months after treatment terminated, there was only 30% of the patients relapse, right? But I always say, why don't you follow them for five
Yeah.
years? Because you'll see maybe 100% of them needed to return. And so they all would have benefited from longer treatment. But we don't measure in that way because that's expensive to do, and it doesn't uh, lend to their argument, right? That you can do good treatment in whatever 10 sessions.
And also, I mean, even if you measure for a longer period of time, ultimately, what are you measuring?
Right. So many
Bec-
factors. Yeah.
yeah, because you can, you could have a good score on the Beck Depression inventory, and you can, hold a job down and do all these things, but just kind of lack.
Vitality or,
Yeah,
yeah, a passion for life. Yep. So an understanding of, yeah, of the world, all those things. So they're not looking at that. So, um,
I imagine, the integration in your work of modalities outside of the psychodynamic, that when that comes into play, it is, I imagine, around issues of functionality. Am I?
yes, yeah, but it's also, I mean, here's the thing, like, if Freud was alive today, I believe he would be much more open to what's going on today than people think.
Yeah.
I mean, I think because he thought of it as a scientist, and so he probably would see things like, I mean, I use, like, in Freud's time there wasn't a this positive psychology psychotherapy. It's really, I would say, only in the last 10 years has been formulated really well to look at people's strengths and to see how one's strengths can be used in the treatment room, to help someone who's suffering from any of the disorders, that even some, from the severe disorders like bipolar personality disorder, bipolar disorder, borderline personality disorder, severe depression. And so I think integrating these theories into it is very holistic and a more under you get an understanding of the whole person more. And I think where where I would have a problem with contemporary theory, if it's to align with this DSM medical model where we're just looking at symptoms and not the whole person. And when I'm training my students, I say when you're listening, and especially even in intake, to make a diagnosis, because most of them have to make a diagnosis in their first or second sessions with their patients, and they're so set on thinking like, so what are the things the patient needs to say for me to make this diagnosis? And I said, I don't want you to listen that way because the patient's giving you their entire selves.
Hmm.
You need to listen to, like, so when a patient is telling you a story, I want you to listen how closely, how observant this patient is of their environment, what they're picking up, what from the emotions to the words that people use. And those are all strengths. If a patient is telling a really good narrative, you should write that down. DSM doesn't care about stuff like that, but you, as their person who's potentially going to treat them, will need to know that this is their strength, or you need to know that whether this person practices some type of mindfulness exercise, or whether it be gratitude, or yes, etc. If they share that in the initial intake with you, then you know that this is how they cope, and you know that this is how they should continue to cope. Maybe you have to develop other ways of, psychoanalysts would say defense mechanisms, healthier defense mechanisms, but you need to track the entire person.
Hmm.
And I think so. I think the new theories are can be good if they allow us to look at people in a more complex and holistic manner,
Hmm.
rather than a traditional DSM, which again is also pushed a lot in some of these theories, newer theories
Hmm.
and approaches. Yeah.
Yeah. So and uh, even even not just segmenting the person off in that way, but also just human nature.
Yep.
Focusing too much on specific learning patterns, or yeah, you get and in my work, I really like a lot of the stuff from the third wave behavioral therapies. I utilize a lot of stuff from acceptance and commitment therapy, which is very functional, but I try to be kind of careful with that because it can very much become a hammer that makes the world a bunch of nails.
Hmm.
Um, we've talked a little bit about your work with children. Do you find that the degree to which you lean on one more, well, not to say lean, maybe utilize is a better term, one modality over another, is that different depending on the age group of the client?
It really doesn't. I know, you know, historically there was this huge argument between like Anna Freud's camp and Melanie Klein's camp of can young children be analyzed.
Mm-hmm.
Anna Freud didn't feel like they could. There wasn't enough ego development yet and stuff. But I mean, they're so technical in that way. And I think when I sit with a client, whether it's a child, or adolescent, or adult, um, a lot of times it's hard to describe it, but what unfolds in the time that we're together helps me guide me in saying like what am I going to do, and am I going to be more directive, or am I going to be more kind of just sitting back and observing, because I'll figure out what they need initially. And obviously with adults, if an adult comes into session and is expecting me to say something, after the initial, like, how are you doing, and if there's a silence, I tend to always, if it's an adult patient who is not obviously in a severe state of turmoil, I expect them to start the session, even
Mm-hmm.
if there's long pauses, because I think there's a lot we can read in those silences. Uh, but for a child, I'm not going to make them, they don't have that type of
Yeah.
ability. So there's different ways of just, if a child is having difficulty starting the session, I'm not going to make them sit. They're not there yet. And so there's different things that you do. Um, but at the end of the day, it's informed by what the client is bringing in at that moment. So about where you lean, like what do you want to do?
Mhm.
What kind of questions would you ask? If you can ask any questions at all. So
When you're working with a client for a period of time, um, and I imagine that with some of your clients, it leans more. No, I keep saying lean.
okay.
uh, you end up it takes more of a psychoanalytic form than with other clients. When working with someone for a long period of time, and then something comes up where it feels appropriate to utilize something from another modality. What can that integration ever be tricky? Is there ever any concern that it will break the flow or some of the more relational stuff?
No, I mean I think when you talk about theories in distinct ways, it can make it seem like, yeah, you're not following a true way of working,
Mm.
or you're not loyal to a method. And I think because what we started out before the early session, I think there's a lot of overlap now between, there's even the contemporary theories are extrapolating from dynamic
Mm.
theory. So I feel in that way you don't feel like you are, but it's also um, like sometimes you have to be more directive in a situation where like I work with a lot of adolescents, and sometimes you have to be quite direct
Mm-hmm.
if they're going to make a decision that's going like a really poor decision. And I'm not going to trust that I'm going to have 3 to 4 months to work this through in a way where they're going to make this mistake by the time we're going to be able to really get to it in a level where I would like to process it. So,
Mm-hmm.
like, I'll give an example. I was working with an adolescent boy who was talking about, and I've been seeing him for at least about 2 years at this time. So we have a really good relationship and uh, a good alliance that I could probably say anything. But he was talking about how a friend of him had approached him and said, we can make a lot of money without much risk if we start um, dealing to basically sell pot on a
Mm-hmm.
big level. And he wanted me to kind of give my thoughts on it, right? Like what I thought. Because I knew he was savvy in other ways in making money. Like he would buy sneakers. Uh, the first day when they were launched, he would, use all his savings and buy 10 and then, I don't know, it's like sell them for double the price or triple the price sometimes,
Mm-hmm.
because they were limited series. And so he was savvy.
Yeah.
But they wanted to take it to another level. And was I going to sit there and do 3 months? I wouldn't have 3 months. They
No.
were going to start this within a couple weeks.
Mm-hmm.
So get the ball rolling on, putting money into dealing pot through the mail, how to
Mm-hmm.
source it in other states and to bring it. He's bringing up things like, interstate laws and blah, blah, blah. And, you don't sit there and with an adolescent boy who's a minor, eventually I'm going to have to talk to his parents about it and work this through. You just don't have that time.
Mm-hmm.
And so you do have to integrate other methods that are, or I would say more cognitive behaviorally based than to go like what's the root of this? Like what's the root of you needing to,
Yeah.
make more money or to get something this way or pull something over someone else or what would it mean for you to have to, I don't sometimes, I will get to that later, like explore that. But I remember in the session when that was happening, I was geared towards, I have to push him towards a way where he's not going to take the next steps to do this.
Mm.
Not demanding it, but to kind of really put it at the forefront rather than saying what is the unconscious root of needing to do something like this. Um, so yeah, and I don't think the patient in that situation felt like, was there a huge shift in the way I was working?
Yeah.
Um, I don't think patients think of it in that way. So I think it's more how we do it, But um, yeah, and I think, I would say I'm curious here how we all work. It's so unique to ourselves, but I when I'm trying to teach my students how to work, I try to teach them how to work in a very I always ask like what are you doing in the room?
Mm.
What's your thought process? And for me, when I was starting out, I wish someone would have given me a concrete framework. And I don't like when therapists say, well, there isn't a way, because there is a way. I mean, if we're talking about dynamic theory, I lean toward more object relations and interpersonal theory. So I tell my students, this is what you're going to do. And I tell them, not telling them that this is an analytic way of working,
Mm.
but I say, you listen to what the person is talking about, right? And obviously, most people will be talking at the core of what most people are talking about, whether it's things at work or in the home or in their own lives. It all comes back to relationships, even if it's a decision, something like they want to figure out what they're going to do for their future. It's
Mm.
all relation based, meaning a sense like, will people respect this decision? Will people agree with me? Will people think I'm, so I always say, so you listen to it on a superficial level, and I don't mean superficial, it's like it's meaningless, but just the narrative, right? And
Mm.
then you listen within that story, um, how they are perceiving others. Are others perceived as benevolent? Are they critical? How are their people perceived in their life?
Mm.
And then in the story, you have to talk about this, how they perceive themselves. Um, are they doubtful? Are they reticent? Are they allowing themselves to feel certain emotions and not others, the self? Like, what is their. And the last thing you're listening for is, um, how does that impact this relationship in the room, the here and now with the therapist, right? And I'm spelling this out. I always tell students the word is the cost. So you're listening, the cost, the C is the concrete story that they're telling. The O in that story is the others. How are others? The S is the self, how they perceive the self. And the T is how they perceive the therapeutic relationship.
Mm.
And I said, and if you just listen to it on that level, you're going to learn a lot about what you need to know. So as they're telling this story, you're always asking for like clarification to figure out, so you can figure out how they really see other people. Oh, so you think that your mom is going to do this. So tell me about that, right? And then they're going to talk, you're going to see the self. But what you have to be mindful of is, and this is where it becomes analytic, is how others and selves are perceived in the story is happening there right in the room.
Mm.
And here is where people think, well, that's so analytic. But I said like, well, it is. But if you want to look at it through a contemporary lens, it's mindfulness. It's what's actually going on in the here and now. So the as the patient is telling the story, like let's say is making a big life change, they're concerned about what other people are thinking, but they're also thinking about what the therapist is thinking.
Mm.
Are you going to think that I'm stupid to walk away from a secure job and to do this, to study art? Are you also going to think that? Are you going to judge me? And because if you are, then what can I say in this room right now, right? That is safe or what? And so I always say that's what you're listening for. You're listening those four elements in that. And you're listening it in a way to improve over time the patient's ability to, if you're looking from an object relations point, improve the quality of all their relationships, right? The one that's in the room right there, that's what we're working on, right? The patient could sometimes say to me, like, I'm kind of embarrassed to even tell you what I'm about to do, right? So
Mm.
that's the here and now. But that they're telling you something about other people in their lives too, right? So if they're able to do that in the room because there is this trust and that you haven't been critical and you've kind of been non-judgmental and created space for that, then obviously that is going to hopefully trans transform and in themselves and saying like I'm going to try to attempt to do this in my relationships outside of the consulting room, right?
Mm.
Um, what we're helping them there in that situation, developing a sense of their own identity, a core of who they are, right? This is what I really want to do. I don't want to stay at this job that everyone thinks I should because it's secure and it's their status. I want to do this with my life. So um, in the room, you're constantly asking them to develop ways to observe their own thoughts and feelings as we're analyzing this. So all these things that we are doing in this session from just looking at that cost, and I should explain that better because it's not my model that I work with. Some I borrowed from a Canadian psychoanalyst, but the
I like it a lot.
the cost the cost is if the patient stays in relationships that are unhealthy or dysfunctional. That's the cost. So they bring us these stories at a concrete level. We see how they are perceive others. We see how they perceive themselves, and then the T is the therapeutic relationship in the here and now, and what is
Mm.
being brought into the room. And I always tell work with that. If if you get lost in you start getting lost in the session because the patient is becoming emotional, yes, you can work with them to help calm them down, but you're still listening to those things. What triggered the patient to start to hyperventilate in session? right? It's it's the story that they're telling about how others were going to perceive them or have perceived them in the past, how I've been shamed, how I've been thought of as, making the person who makes poor decisions, you know. And so all that is becoming overwhelming. You reading the affect, but if you go back to those four letters, um, it's going to help you structure the session and to go like, what am I going to ask, right? How am I going to move this forward? And I think most of the time, I think the other three things that I tell them to do in the session is you're gonna clarify, confront, or interpret. Those are the only things that you're gonna do. Because if you tell people like you have to do all these other things, and clarification is really easy. Tell me more about that,
Mm-hmm.
right? Confrontation is like, when you talk about this person, it seems like there's a lot of anger. You're confronting, right? And then you use interpretation. Rarely do you interpret. You have to be really sure about this. And this goes back to this whole idea of like, if you're not in your own therapy, you don't know, you can't gauge how difficult it is to hear an interpretation. And so I always say in a session, have one, maybe two.
Mm.
You can't have five. When you interpret five things in a session to a patient, that's overwhelming them. They're going to leave in a worse state than they
Mm.
were when they walked in. So choose carefully about what it is you want to interpret, because it can make it, even if you do it in a respectful and a genuine way, it makes the patient feel like I'm an idiot. Am I an idiot for not seeing that? Like how are you able to see that and I'm not able to see that? Like,
Mm.
and if you do that five times in a session, then the patient leaves feeling extremely dependent on the therapist and the process. And that's not the goal of treatment, right? The goal of treatment is for us to give them the tools, right, to do that on their own so that they will jump to it. So when you make the interpretation, they're like, I was just going to say that. I was going to say that, Dr. Bowie. I made, like I was just gonna, I'm so glad you said that. You said it better than I, but I was thinking about that, how I'm behaving exactly the same way now as I did at my last job. This is my
Mm.
pattern, right? So the therapist doesn't have to appear like, this wise person who the patient depends on. Rather, the patient you make the interpretation at the right time when you feel that the patient's going to be able to hear it and be like, I got it. You're right. You said it better than I did, but I felt that inside already. Um, So yeah, follow the cost model. I would say it's very simple, and the idea that it costs the patient if they continue to go down these using these relational patterns. But then those are the only three things you do really is you get clarification, you confront, and you make interpretations every once in a while. And I would say like, is that all treatment is? No, but if you give new clinicians a model to work with, and then they start going off and doing work, and like you said, like I like your comedian analogy. They get more comfortable with who they are. They
Mm.
get more comfortable with integrating other theories, and they watch themselves saying like, it seems like you're overwhelmed talking about this at work right now. Let's take a break and let's do some breathing exercise that we did
Mm.
before to help you. And so when you're at work and this happens again, I want you to be able to walk yourself through this. And that people would say, that's not dynamic. Well, it doesn't have to be dynamic,
Mm.
but you're giving them a tool that they're going to be able to use in the session with you to feel comfortable. And then when they're out there in the world, be able to apply that themselves. And I would hope that most dynamic analysts would not be against working that way, where you talk about when you integrate something that is outside of, uh, the traditional practice.
Yeah.
Yeah. Sorry, I feel like I just went on a
No, that's
ramble
what
with
you're
you. Yeah.
supposed to do.
Yeah. Okay. I'm sure if you have questions
Well,
yeah.
I in the anecdote that you brought up when you're introducing the cost framework to students, and they go, "Well, that sounds very analytic." That kind of brings to mind, and I hope it's okay to talk about this, but your experience being a primarily psychodynamically oriented clinician and teacher in a general counts the teaching that teaches in a count like a what's the word I'm looking for? A counseling program and a psychology program that are multi theoretical, but
Right.
not primarily psychodynamic.
Yeah, like no one is. I mean, yeah, no one in my program is psychodynamic.
Yeah.
And I would say when I interviewed for my position, that was a concern among the faculty. So that was
Mm-hmm.
one of the key decisions whether we would hire somebody who comes in with this orientation that isn't. And remember, most people who aren't familiar with psychoanalytic theory and contemporary psychodynamic theory have not even looked at the empirical studies, right? So
Mm-hmm.
they're looking at a very how they studied Freud, and it's they just feel like it's not something that is scientific, and it's a very, I guess, distorted view of Freud, but incomplete view of psychodynamic theory, definitely.
Mm-hmm.
And so it came down to the decision, like where certain people said, well, don't we want our students to be exposed to the different schools of thought? So you can make an argument for him not being here because he's coming in with an orientation that maybe not be empirically validated as others, but he's also giving our students a different way of thinking. And so that won out. So in that sense, I feel comfortable with the program enough that majority of my colleagues felt that way, that
Mm-hmm.
obviously they made the decision to say to move forward with my hire because they believe in this way of looking at, like you said, multiple perspectives rather than just saying we should have one that dominates, right?
Yeah.
Um,
It's I'm sorry, it's just kind of wild. I mean, my understanding is as far as clinicians that actually would describe themselves as being of a particular theoretical orientation, psychodynamic is either the most or second most common of people who aren't just saying eclectic.
mhm.
So the idea that it's like, oh well, we'd have to include that almost as an afterthought, they give this idea, this well-rounded idea, it's absurd.
Well, I also think, let's say if you were in a program that didn't have psychodynamic training integrated into it, I
Hmm.
would think once you started practicing in, you know, beyond your education, I would think there would be a pool to go deeper.
Yeah.
And you would look for like a theory that would allow you to do that. And that's where dynamic theory lends itself really well. And so I think when you're meeting clinicians out in the world, and many are more open to the idea of dynamic theory, it's because they probably in working in the field really feel like these other theories that they're with are limiting
Hmm.
and not complete in how they are seeing their work with their patients. And so, I mean, if that's the case, then it's really promising, right? That I don't care how psychodynamic theory remains relevant as long as it's still relevant.
Yeah.
Um, whether it's in the universities or just people practicing independently. So,
Yeah. Yeah, and this came up in a previous episode, but in a lot of the new modalities, there seems to be a heavy borrowing, either, in the case of something like I think schema therapy, where it's very open about what it borrows from
hmm
psychodynamic thinking, or I mean, internal family systems just seems to have such a psychodynamic bent to it.
hmm
Just um,
but even but mindfulness
mm,
is like when Freud talks about the transference in the room, he's talking about a really deep level of mindfulness, and that he's saying what I don't okay, you can bring all this stuff out, you can tell all these stories, but Freud said, let's look at what's happening in the room.
mm,
And most therapists who are not dynamic don't care as much as what's happening in that relationship in that room.
mm,
Um, you know, like Freud or the psychodynamic therapist can be like, you know, in this room, we it seems like we can't. There's certain emotions that can't be expressed in this room.
mhm,
And that happens within families, but that happens in the consulting room because the patient won't allow it in because it's too scary or it's whatever. But I think we as analysts are mindful of that. And we want the patients to be mindful of that. Like I always say, patients that I've seen for a long time, and they're the good patient. I will say stuff like, we've been together for a while, and it's just really, I find it really hard to fathom that you haven't been frustrated and angry with me.
Yeah.
Um, I mean, you come here week after week, and I listen to you, and I ask these questions, I make these comments, I make interpretations about what's going on, and you seem to accept it. And I'm wondering, haven't I been off? Haven't I been? And I remember saying one time, I don't know, telling maybe a little bit too much about me, but um, it was a time in my life when there was a family member who was dying,
Mm.
had a terminal illness of cancer, and I was flying back and forth from the East Coast to West Coast to be with this family member, and I was tired. I wasn't getting a lot of sleep, and I was seeing a patient that I had seen in psychodynamic psychotherapy for probably about a good 6 years. Um, she was doing well, and she kind of just wanted to stay in treatment beyond what we were talking about earlier about the she was able to function, the symptoms are gone, and she liked the process, and she started seeing it as like an investment in herself. She's a professional, and she was just like, this is how I'm gonna treat myself. People buy nice bottles of wine, I'm gonna go to therapy and just kind of learn about myself and figure out how to understand the people in the world and myself in the world, and so the sessions were good, but I fell asleep in one of the sessions.
Mm.
Not like a snore full set. I was, like your eyes get tired, and you kind of nod off really quick and you catch
Sure.
yourself. So that happened. It wasn't like it was. And she said she noticed. She said like, "Oh, you're really tired.
Mm.
Are you okay?" Um, and I just remember in that moment just thinking, you know, um, is the patient going to be angry? Here she is paying for this my time, my session, and I'm falling asleep. You know, um, but she wasn't angry. She took care of me. I felt in that moment, but I also felt in the back of my mind that this patient was always the good patient in some way, and eventually I brought that up later on. I didn't feel ready to bring it up because I didn't want to reveal so much about why I was so tired
Mm.
and stuff like. But we brought it up, and she was able to, on a certain level, express some frustration, right? But then we were able to talk about in the years of working together why she wasn't able to express frustration with me. And she was very honest, and I felt this was like 6 years in the treatment, right? And you're thinking, and she said like basically what if you read Kleinian theory about the good object, she said, "You're the good person in my life.
Mm.
You are the only person in my life so far who has been this good to me. And I
Wow.
didn't want to see you as someone who is flawed, that someone would give up and lose and would fall asleep in the session." So, yeah, she was able to say that, and but that took a long time, and that took me to fail almost in a say that most analysts would say, how do you fail? And not in a sense that it's intentional fail, but to fall asleep on a patient because I wasn't taking care of myself enough to get myself to the level, and to have her talk about eventually why she needed to hold me in that way, why she didn't want to criticize me when I made interpretations that were incorrect, or when I asked questions that she felt were inappropriate, to not
Mm.
be able to do that. And then I feel like after that, the the relationship grew and how it should grow. Um,
It,
yeah,
it brings to mind my perhaps poor understanding of Kohut, where a lot of the work gets done when the therapist messes up. That
yeah,
that
yeah,
optimal frustration.
yes, yeah,
Yeah.
yeah. And but it's both ways, right? It's the therapist failing, but also the patient being able to ready to say what they need to say about it, right?
Yeah.
Rather
Yeah.
than her just saying maybe early in treatment not being able to trust me enough to say like, oh, I fall asleep at work sometimes too. You're excused, and really, and not really talking about what it means when someone you depend on lets you down.
Yeah.
some way, or misunderstands you, or yeah, hurts you. Yeah.
I think we're coming close to the end of our time
Okay.
today. But I guess if there's one thing I kind of wanted to check in around towards the end would be well, I know you first and foremost as an educator, so what you would perhaps have to say to somebody who's thinking about maybe applying to a graduate program in counseling or social work or even in psychoanalysis. I kind of imagine that those might be two different things to say.
Right.
Yeah.
So if they're, I mean, if they're curious about going into the field, how I would like what I guess there's so many ways I could. I mean, because this happens to me 100 times a semester, just because there's so few. Like I've become the faculty in the department that everyone refers to if a student hints at uh, wanting to create mental health. Where last semester, during the pandemic, I conducted 2 workshops
Mm,
called Careers in Mental Health, where students can come in and I kind of introduce them to the different career paths, make the distinctions between each, and then they get to ask questions, right?
mm.
But I think you're asking a deeper question, more about should they pursue it, or are they
I
fit
le-
a fit for it, or what do you?
I'm not sure if that's what I was asking, but I kind of like it better than what I was
Oh,
asking.
okay. Because I always when I have time, and these workshops don't lend to it because I'm doing 30 students in one of these workshops. Before COVID, when students could come to my office hours, they would sit with me, and I would ask them questions about, why do they want to do this type of work, and I tried to give them a sense of what the work entails rather than this idea, this fantasy idea of what they see in the media. Um, and a part of me kind of wants to scare them off too, not in the
Mm,
sense that uh, I want them to really want it.
mhm,
So I say like they'll say like most students come in and will say like I've always been the person in my family or my peer group to help others.
mhm,
That people have told me that on some level I'm a good listener, um, that I give good advice. And I'll say stuff like, in all those situations, you're helping people you care about, people who, um, you want to see doing better in life. You may share similar values and histories, but are you willing to help someone who you don't have those good feelings towards?
mm,
And I always say, like, you know, you a lot of people say they want to work with people who have been victimized, but how comfortable would you feel working with someone who, the perpetrator
mm,
of violent acts? I want them entering the profession curious about the human condition. So when we say that Freud or therapists have to sit in a non-judgmental way, we really have to mean that. So for me, I'm more interested in your curiosity about human behavior than your desire to help. That
mm,
desire to help is secondary because the desire to help should exist in everyone who is healthy. And you can go into any profession or stay in the profession that you are. You can be the cashier at the Hannaford supermarket and be the most helpful person to bring a smile to somebody's face, to
mhm,
help people when they need something assistance in that way in the store, and make a difference every day in your job. But why do you want to do this? Why do you want to help in this way with mental health, to be a therapist? And I think that goes back to being curious about the human condition. So I want them to hear how much they're curious about Oh yeah, I would want to help that person who's a perpetrator because I want to understand why they do that. How did they get there? What would motivate someone to behave in that way? If they answer in that way, then I feel more confident in saying you should do this. But if they don't go in that direction, to me, I'm not saying they can't learn or they won't be a great therapist. They don't have opportunities to grow in that area. But to me, they're not the student that I'm thinking, I can write a letter for you.
To
Take
me,
my course, I want you're on the right track. So in that sense, I'm more curious about they're curious about curiosity in the human condition than their desire to help. So
I would think that the real hazard is, they might be very bright and altruistic, and they might be technically a very good therapist, but they just get bored and burnt out.
yeah,
Yeah.
yeah. Or people say like I was helped by a therapist, so now I want to help other people.
Hmm.
And I'm just thinking, but we have to your therapist helping you is one treatment, right?
Hmm.
Does that mean, and let's say if they come in and I said, so let's say you start working at an agency and they want you to run a group for people with on the autism spectrum, which isn't something you are identify with being on the spectrum. Are you willing to just it has to go beyond like somebody helping me.
Yeah.
It has to be like people are presenting with different, trajectories and traumas and struggles in life and wanting to understand all those things and being able to commit yourself to wanting to do that on that level rather than just saying, I want to help people because someone helped me once. It's not, I don't know, that it's not enough for me. I'm not, it's a good start, but it's not enough. And so the student can go on and hopefully in their training understand that that's not enough. That is, like you said, they'll burn out if that's the motivation. It's just it won't carry them.
I think that's appropriately complicated advice. Because it's not definitive, but I don't think it should be.
Mm-hmm.
Yeah. You're posing a question.
Mm-hmm.
Yeah. All right. Well, unless there's anything that you feel like we didn't get to, we could probably wrap up here.
Oh, I definitely want so for anyone who's listening, that cost model is made. I always want to reference people who've done the good work. It's a psychoanalyst by the name of Allen with an Allan Franklin, and he's a psychoanalyst in Canada, and he's obviously more object relations, but that model comes from him. And if anyone wants to read him, he's also someone who can explain the theory really well and how it's applied in the room. And I think when I talked to you previously, that's how I work. I
Hmm.
want to know what's going on in the room. I want to be explain it to others what's going on in the room, but also have them be able to understand what's going on in the room with them. Because I think the work that we do is enormously challenging, and we can get so easily lost in it. And so when you find someone or something that makes that process of being in that room easier, it's gold.
Hmm.
So he's one of the people who have been able to do that.
Yeah, I think.